Welcome to Deep Dive Ortho, the show dedicated to really cutting through the complexities of orthopedics and bringing you those vital insights that, well, truly matter in clinical practice. Today, we're tackling a complaint I'm sure many of you encounter almost daily, that persistent, nagging shoulder pain. You know the one, it just won't quit. Picture your patient, perhaps a keen amateur swimmer, maybe a builder, or even just someone struggling to reach for a book on a high shelf. They describe an ache, often gets worse at night, sometimes it radiates down their arm. It's a remarkably common scenario. Shoulder complaints are prevalent worldwide, and certainly here in the UK, roughly a quarter of individuals seeking treatment from their GP for shoulder discomfort are experiencing what we're about to explore. We're talking about subacromial shoulder pain, often referred to as rotator cuff tendinopathy or shoulder impingement. It is without a doubt the leading cause of shoulder discomfort we see, a truly ubiquitous presentation in clinical practice. To guide us through this critical and often nuanced topic, we have with us a true authority in orthopedics, Professor Mo Imam. Your profound clinical insight and extensive experience are precisely what we need to illuminate the intricacies of this condition. Our mission today is really to demystify shoulder impingement syndrome. We'll delve into its origins, understand its varied clinical presentations, navigate the diagnostic pathways, and crucially dissect the subtleties of its management. We aim to move beyond that surface level understanding to provide you with a truly comprehensive and actionable deep dive. So let's get started. Okay, let's begin by setting the stage then. When we talk about subacromial impingement, what exactly are we defining? And, well, what makes it such a prevalent issue in our clinical practice?
Thank you. It's an excellent starting point because, as you rightly highlighted, its ubiquity is, well, it's striking. Subacromial impingement is fundamentally a painful condition of the upper limb, specifically impacting the shoulder. At its core, it arises from the compression, the inflammation, irritation, and actually, over time, the degradation of the delicate anatomical structures situated within that critical area we call the subacromial space. Think of it as a structural narrowing, perhaps, or maybe a functional constriction that repeatedly squeezes these soft tissues.
Okay, so it's that space that's the key issue.
Precisely.
Yeah.
And the statistics really underscore its significance. Globally, subacromial impingement accounts for a staggering 44% to 65% of all shoulder complaints.
That's huge.
It is. That's a huge proportion of patients presenting with shoulder issues. And closer to home, here in the UK, approximately 1 in 4 individuals who present to a general practitioner with shoulder pain will be diagnosed with this condition. What's particularly challenging, I think, for both patients and clinicians is its chronic and often relapsing nature. We know that over half of patients, about 54%, report persistent symptoms even after 3 years.
3 years, wow.
Yes. So this isn't just an acute issue. It requires a sort of long-term strategic approach to management, not just quick fixes. What's crucial to understand, I believe, for us as clinicians is that shoulder impingement isn't always a static, isolated diagnosis. Increasingly, we view it as the initial stage, perhaps a critical warning sign in a progressive continuum of rotator cuff disease.
A continuum, right?
Exactly. This journey often begins with relatively mild impingement and perhaps associated bursitis, an inflammation of that fluid-filled sac that cushions the tendons. If those underlying contributing factors aren't adequately addressed, or if the mechanical irritation persists, well, it can progress. The next stage often involves the development of partial thickness tears within the rotator cuff tendons.
Okay.
From there, these can evolve into full thickness rotator cuff tears, which, as the name suggests, go all the way through the tendon. In more severe, long-standing cases, these can become massive rotator cuff tears, encompassing multiple tendons. And ultimately, in the most severe and chronic instances, this degenerative process can culminate in rotator cuff tear arthropathy, where the integrity of the joint itself is compromised.
So it can get quite serious if left unchecked.
Absolutely. So the key takeaway here is that early identification and targeted intervention are absolutely vital. Our role as healthcare professionals is really to intervene at the earliest possible stage to either prevent or significantly slow down this degenerative cascade. The aim is to preserve the patient's long-term shoulder health and function. It's about proactive management, not just reactive treatment of symptoms.
That concept of a continuum is incredibly insightful. It really shifts our focus from just a single diagnosis to a dynamic process. Given that, let's really hone in on the mechanics. Can you walk us through the essential anatomy of the shoulder and explain the specific ways this impingement actually manifests within such a complex joint? What are the key players we need to keep in mind?
Absolutely. To truly grasp the mechanisms of impingement, We need a clear mental map of the shoulder's intricate architecture. It's a remarkable feat of natural engineering, designed for an extraordinary range of motion, but that mobility also contributes to its vulnerability, you see. We're primarily concerned with three main bones here. The humerus, which is your upper arm bone, the scapulae, or shoulder blade, and the clavicle, your collarbone. These bones form several key joints. The most mobile, indeed one of those mobile joints in the entire human body, is the glenohumeral joint. That's where the spherical head of the humerus articulates with the shallow glenoid cavity of the scapula. This allows for vast, multidirectional movement. Additionally, we have the sternoclavicular and acromioclavicular joints, all contributing to the overall synchronous movement and stability of the shoulder girdle. Right, so it's a coordinated system. Exactly. Now, central to shoulder function, and paramount in our discussion of impingement, is the rotator cuff. This isn't a single entity, but a group of four critical muscles: the subscapularis, supraspinatus, infraspinatus, and teres minor. Their tendons originate from various points on the scapula and then merge, forming a cuff that inserts onto the lesser and greater tuberosities of the humerus. Collectively, they provide dynamic stability to the glenohumeral joint, essentially holding the humeral head firmly within the shallow glenoid.
Keeping it centered.
Precisely. They are also responsible for a wide array of movements, from abduction, lifting your arm away from your body, to internal and external rotation and various degrees of flexion. Any weakness or dysfunction in this coordinated group can significantly impact shoulder mechanics.
I see.
The anatomical epicenter of subacromial impingement is, of course, the subacromial space itself. Imagine this as a narrow, crucial passageway situated directly beneath several bony and ligamentous structures. Specifically, the acromion, that bony projection forming the highest point of the shoulder blade, the coracoid process, the acromioclavicular joint, and the coracoacromial ligament, which bridges these structures. Okay. Within this confined space, we find the critical rotator cuff tendons, predominantly the supraspinatus tendon, and a lubricating sac known as the subacromial bursa. The bursa's role is absolutely vital. It acts like a frictionless cushion, allowing for smooth gliding of the rotator cuff tendons as the arm moves, preventing friction between the tendons and the overlying bone.
Like a little bearing.
In essence, yes. So what exactly happens when impingement manifests? We're essentially describing what occurs when this delicate balance within the subacromial space is disrupted. Firstly, you can have tendinitis, which is simply inflammation or irritation of one or more of these crucial rotator cuff tendons. Secondly, bursitis often accompanies this, which is inflammation and swelling of that lubricating subacromial bursa, often a direct response to repetitive friction or compression. And this leads us to the core mechanism of impingement. During arm elevation, particularly with overhead activities, the space between the acromion and the rotator cuff tendons naturally narrows. If this narrowing is excessive, or if the tendons or bursa are already inflamed and swollen, the acromion can literally rub against or impinge upon the underlying tendon and bursa. This repetitive, painful compression means the humeral head is effectively applying a compressive force to either the rotator cuff, the subacromial bursa, or both. A key concept here is the impingement interval, the precise space between the undersurface of the acromion and the superior aspect of the humeral head. Any compromise to this interval, whether due to structural issues like, say, bone spurs or dynamic factors like altered movement patterns, contributes directly to the painful symptoms and, well, that degenerative cascade we discussed earlier.
That's a fantastic breakdown of the mechanics, really clear. So we've identified the what and the how. Now let's explore the why. What are the primary triggers for these issues, and who in our patient population is particularly susceptible to developing shoulder impingement?
Indeed. Understanding the why is pivotal for both effective prevention and truly targeted treatment strategies. We classify impingement in a few key ways, which helps us delineate its origins and guide our approach. First, by location. We have external or subacromial impingement, which is the most common form we're discussing. This is the mechanical or physical encroachment of soft tissue within that subacromial space we just detailed.
Okay.
In contrast, there's internal impingement. Here, the rotator cuff tendons, typically the supraspinatus and infraspinatus, actually get pinched between the humeral head and the glenoid rim, rather than under the acromion.
Ah, so a different mechanism entirely.
A different location of pinching, yes. This type is far more commonly observed in overhead throwing athletes, like baseball pitchers or javelin throwers, due to the extreme positions their shoulders adopt during their sport. Secondly, we classify impingement by its underlying cause, primary versus secondary. Primary impingement involves a structural narrowing of the subacromial space. This could be due to an abnormally shaped acromion, for instance, a hook type 3 acromion, which we'll discuss, or simply due to swelling and thickening of the soft tissues within that space, like a very inflamed bursa.
So the anatomy itself is the problem.
In primary, yes. Secondary impingement, on the other hand, presents with normal anatomy at rest, but the impingement occurs dynamically during motion. This is often a result of rotator cuff weakness or fatigue, which allows for uncontrolled cranial translation of the humeral head. In essence, the humerus rides up too high in the joint.
I see.
Another significant cause of secondary impingement is weakness in key scapular stabilizer muscles, such as the trapezius and serratus anterior. If these muscles are weak, they limit the proper external rotation and upward elevation of the scapula during arm abduction, further narrowing that critical subacromial space and predisposing to impingement.
So muscle control is key there.
Absolutely crucial in secondary impingement. To add another layer of understanding, a classic framework by Neer categorizes shoulder impingement into 3 stages of severity. Stage I primarily involves edema and hemorrhage within the bursa or tendon, typically seen with acute overuse. Stage 2 is characterized by more significant fibrosis and irreversible tendon changes, indicating a more chronic process. And then, Stage 3, the most severe, often results from chronic, long-standing fibrosis, leading to a frank rupture or tear of the rotator cuff tendon itself.
Right.
This staging helps us appreciate the progression and the potential for chronicity if the condition is left unaddressed.
That makes sense.
Now, let's delve into the specific causes, which we can broadly categorize as intrinsic, related to the tendons themselves, and extrinsic, related to external anatomical or environmental factors. Intrinsic causes frequently include overuse, especially repetitive overhead motions common in many sports and occupations. This repetitive loading can lead to what we call tendinopathy, a degenerative process within the tendon.
Wear and tear, essentially.
You could frame it like that, yes. Age-related degenerative changes are also a significant intrinsic factor, increasing the tendon's susceptibility to injury as we get older. Acute traumatic injuries, such as direct falls or blows to the shoulder, can also precipitate rotator cuff damage. And, as discussed, weak rotator cuff muscles are a major intrinsic contributor, leading to inefficient shoulder mechanics and increased stress on the tendons.
Okay, and the extrinsic factors.
On the extrinsic side, we look at the surrounding structures. Acromion morphology, famously classified by Bigliani, is a significant factor. Type 1 is a flat acromion, Type 2 is curved, and Type 3 is hooked. A hooked Type 3 acromion carries a significantly higher risk due to the inherently reduced space it provides for the underlying tendons.
That bony shape matters a lot, then.
It can, yes. While there's some debate around the inter-observer reliability of this classification in research, its conceptual value for understanding purely mechanical impingement in clinical practice remains undeniable. Other extrinsic factors include the development of osteophytes or bone spurs and thickening of the coracoacromial ligament, all of which can further narrow the subacromial space. We also consider associated conditions like ossicromial, which is an unfused ossification center in the acromion posterior capsular contracture, where the back of the shoulder capsule is tight, scapular dyskinesis, which is abnormal movement of the shoulder blade, and even tuberosity fracture malunion, where a previous bone break hasn't healed optimally.
A lot of potential contributors there.
Indeed. Finally, who is particularly susceptible? Age is a clear risk factor. The incidence increases markedly with age, peaking in the 6th decade, largely due to those underlying degenerative changes. Physical activity, particularly participation in overhead sports like swimming, baseball, tennis, volleyball, and handball, places athletes at high risk due to the repetitive nature of their movements.
Makes sense.
Manual labor professions involving repetitive lifting or prolonged overhead arm use, consider painters, construction workers, paper hangers, or even hairdressers, are also high-risk categories. Beyond that, bearing heavy loads, certain infections, and lifestyle factors like smoking have all been identified as potential extrinsic risk factors. And something often overlooked, chronic postural issues, such as a habitually slouched posture, can alter shoulder alignment and contribute to impingement. It truly is a multifactorial condition.
It really is. That comprehensive overview of causes and risk factors truly highlights the complexity. Given such varied etiologies, how do patients typically present in our clinics, and what's our diagnostic pathway? How do we accurately distinguish shoulder impingement from other conditions, especially considering that continuum of disease you just outlined?
That's a crucial next step, because the diagnosis of shoulder impingement is fundamentally clinical. It's primarily driven by a meticulous patient history and a thorough physical examination. Imaging often serves to confirm our suspicions and, importantly, rule out other pathologies.
Right, history first.
Exactly. The cardinal symptom, almost universally, is pain. Patients will typically describe a dull ache, often insidious in onset, developing over weeks to months without a clear, single traumatic event. However, it can occasionally manifest suddenly with acute, severe tenderness. What's particularly noteworthy, and a classic differentiator, is that the pain often worsens at night, significantly disrupting sleep, a common and frustrating complaint we hear.
Yes, the night pain is very typical.
Very typical. This pain is almost always exacerbated by overhead activities, lifting the arm, reaching for objects above the head, or trying to place the hand behind the back. Simple, everyday tasks like getting dressed, fastening a seatbelt, or washing and brushing one's hair become profoundly difficult and painful. Characteristically, the pain is described as being localized over the lateral acromion, often radiating downwards to the lateral midhumerus.
Okay.
For our athletic patients, especially those involved in overhead sports, they'll often report pain specifically when performing actions like throwing, spiking, or serving a ball. Alongside the pain, you'll frequently observe stiffness and a loss of active motion, often a secondary consequence of the pain itself. Weakness, particularly in abduction and external rotation, is another common finding.
So the history needs to be detailed.
Meticulous. We inquire about the onset, the quality and intensity of the pain, what makes it better or worse, any previous shoulder injuries or issues, and critically, a detailed account of their occupational and recreational activities, especially any involving repetitive overhead movements. Patients might report some transient relief with rest, over-the-counter nonsteroidal anti-inflammatory drugs, NSAIDs or ICE, but they'll almost invariably note that the symptoms recur upon returning to their aggravating activities.
And then the physical examination.
That's where we consolidate our findings. We begin with inspection, looking for any obvious deformities, muscle wasting, or asymmetry. Palpation often reveals tenderness, particularly over the greater tuberosity of the humerus or the coracoid process. We then assess both passive and active range of motion, noting any limitations, painful arcs, or compensatory movements. A key finding is often weakness, especially in abduction and external rotation, which we always compare bilaterally. We'll often observe scapular dyskinesis and abnormal, uncoordinated movement of the shoulder blade during forward arm elevation.
Checking the shoulder blade movement, too.
Yeah, absolutely vital. It's also paramount to systematically rule out other conditions that can mimic shoulder impingement, such as cervical spine pathology, like a pinched nerve radiating down the arm, glenohumeral arthritis, shoulder instability, or perhaps calcific tendinitis.
Right, the differential diagnosis.
Precisely. Now, to the special tests. While it's important to remember that individual tests often have low sensitivity and specificity when used in isolation, their true value emerges when used in combination as part of a comprehensive clinical assessment.
Okay, which ones are key?
The Hawkins-Kennedy test is a classic. We passively internally rotate the patient's arm with the shoulder in 90 degrees of forward flexion and the elbow flexed to 90 degrees. Pain over the acron is a positive sign for subacromial impingement. The near sign involves the examiner maximally forward, flexing the patient's arm passively while fixing the scapula to prevent compensatory movement. Localized anterior shoulder pain suggests impingement. The Job test, also known as the empty can test, targets the supraspinatus. The patient's arms are abducted to 90 degrees in the scapular plane, maximally internally rotated, thumbs pointing down, and then resisted abduction is applied. Localized pain in the affected arm is a positive sign. We also look for a painful arc of motion, typically where pain is present with active abduction between 70 and 120 degrees and with forced overhead movement.
That painful arc is quite specific, isn't it?
It can be, yes. The Yoakum test, while sensitive, is less specific. It reproduces pain with elbow elevation, while the ipsilateral hand is placed on the contralateral shoulder. For suspected internal impingement, we elicit pain with the arm in abduction and external rotation. Conversely, tests for glenohumeral instability, such as the sulcus sign, anterior apprehension, and relocation tests, are typically negative in pure impingement syndrome, which helps differentiate.
Okay, so a cluster of tests is better than just one.
Absolutely. Moving to imaging, while the diagnosis remains primarily clinical, these studies are often performed to validate our findings, assess the extent of soft tissue involvement, and rule out other pathologies or concurrent conditions. Radiographs or X-rays are usually normal for soft tissues, but are invaluable for assessing bone morphology and looking for spurs.
What views do you recommend?
We typically recommend specific views. A true AP view allows us to measure the acromiohumeral interval. A normal distance is generally 714 millimeters in men and 712 millimeters in women. A reduced interval can strongly suggest pathology. A 30-degree caudal tilt view is excellent for identifying subacromial spurring, and the supraspinatus outlet view is particularly useful for assessing acromial morphology, helping us identify those high-risk hooked type 3 acromions. It's always good practice to obtain bilateral films for comparison if there's any doubt.
For soft tissues, MRI.
Magnetic resonance imaging, or MRI, is widely considered the gold standard for soft tissue evaluation. It provides exquisite detail, clearly showing fluid or inflammation within the bursa or rotator cuff tendons, and can definitively identify partial or full-thickness tears. It's generally recommended if conservative therapy hasn't yielded significant improvement after about, say, 6 weeks.
Okay.
Ultrasound is another excellent, readily available option, particularly useful as a bedside diagnostic tool. It's superb for visualizing soft tissues like bursitis, tendinopathy, and tears. And it can be a valuable alternative if an MRI is contraindicated, for example, due to pacemakers or claustrophobia.
Ultrasound is becoming more common, isn't it?
Increasingly so, yes. It's dynamic and accessible. Additionally, CT arthrography, while less common for initial diagnosis, can also accurately image rotator cuff tendons and muscle bellies, especially in complex cases. The importance of an accurate and timely diagnosis cannot be overstated. It is absolutely paramount for tailoring the most appropriate, individualized treatment approach and rehabilitation strategies for our patients. As I've said, it's primarily a clinical diagnosis, but often beautifully validated and refined by these imaging studies. Many diagnostic criteria even suggest a battery of tests, like needing 3 out of 5 specific impingement tests to be positive to confirm the diagnosis. This integrated approach ensures we're addressing the root cause and the specific stage of the disease rather than just chasing symptoms.
That's a masterclass in diagnosis. Really comprehensive. So once we've reached a confirmed diagnosis, what are the established treatment pathways for shoulder impingement, considering both non-surgical and surgical options? And how do we determine the most appropriate course of action for each individual patient, especially given the range of factors you've already discussed?
The overarching goals of treatment are, quite simply, to alleviate pain and restore full functional use of the shoulder. When we devise a treatment plan, it's never a one-size-fits-all approach. We rigorously consider several patient-specific factors: their age, their activity level, are they a professional athlete, a manual laborer, or someone with a more sedentary lifestyle, and their overall general health and comorbidities.
Right, individualized care.
Precisely. In the vast majority of cases, initial treatment is non-surgical and serves as our first-line approach, typically for a period of 3 to 6 months. This foundational conservative care begins with rest and activity modification. This means advising patients to avoid movements that consistently aggravate their symptoms, particularly overhead activities and reaching behind the back. We often talk about living within the window, restricting movements to an approximate 2 to 3 foot rectangle directly in front of the body. This reduces the mechanical irritation and allows for initial healing.
Avoiding that provocative range.
Exactly. Non-steroidal anti-inflammatory drugs, or NSAIDs, such as ibuprofen or naproxen, are commonly prescribed to reduce both the pain and the underlying inflammation.
Standard first steps.
Yes, but physical therapy is truly the cornerstone of conservative management for shoulder impingement.
Physiotherapy, yes.
Crucial.
Absolutely. The initial focus is on restoring pain-free range of motion. This involves gentle stretching exercises, joint mobilizations to improve glenohumeral and scapulothoracic rhythm, and assisted active range motion exercises. It's particularly important to assess and address any posterior capsule tightness, as a stiff posterior capsule can push the humeral head anteriorly and superiorly, further exacerbating impingement.
That's an interesting point about the posterior capsule. It is often overlooked, but can be very significant. As the patient's pain begins to subside and motion improves, the therapist progresses them to a structured strengthening program. This targets the rotator cuff muscles, with a special emphasis on the supraspinatus and infraspinatus, as well as the scapular stabilizer muscles like the trapezius and serratus anterior. The goal here is to correct any strength imbalances and minimize scapular dyskinesis, which, as we discussed, can contribute to secondary impingement.
Retraining the movement patterns.
Precisely. Adherence to a consistent home exercise program is absolutely vital for long-term success. We recommend a regimen of 3 to 4 times per week, ideally 6 days a week with 1 day of rest. There's strong evidence supporting that dedicated exercise therapy yields superior results compared to placebo in the subacute phases of injury.
So the exercises really do work.
They do when performed correctly and consistently. If rest, medication, and a dedicated physical therapy program haven't provided sufficient relief, subacromial steroid injections can be very helpful. This involves injecting a local anesthetic combined with a corticosteroid, such as cortisone, directly into the subacromial bursa. These agents are potent anti-inflammatories and can provide significant, albeit often temporary, pain relief by reducing the local inflammation.
How are these typically done?
These injections are commonly performed in the outpatient clinic, often with or without ultrasound guidance. While various approaches exist, the posterior subacromial approach is frequently utilized due to its safety profile. It's worth noting that studies suggest ultrasound-guided injections may be superior in terms of accuracy and potentially symptom relief.
Ultrasound guidance improving accuracy, right?
Potentially, yes. For general pain and inflammation management, ice therapy is excellent for acute flare-ups and inflammation, while heat therapy can help relax tight muscles and promote blood flow. It's also important for our audience to be aware that current evidence suggests insufficient support for the routine use of platelet-rich plasma, or PRP, injections for subacromial impingement syndrome at this time.
Good to know about the PRP evidence. So when does surgery come into play?
Well, when do we consider surgical intervention? If a patient experiences severe, persistent subacromial shoulder pain with significant functional impairments that haven't improved after a minimum of 4 to 6 months, and often we extend this to a full 6 months of dedicated, non-operative treatment, then surgery may be indicated.
Okay, after a good trial of conservative care.
Absolutely. The primary goal of surgery is to create more space for the rotator cuff tendons to glide freely, thus decompressing the subacromial space. These procedures are typically performed arthroscopically, often referred to as keyhole surgery, which involves small incisions and a camera.
What are the main procedures?
The main surgical procedures are a bursectomy, which is the removal of the inflamed portion of the subacromial bursa, and an acromioplasty, also known as subacromial decompression. This involves carefully removing any bone spurs on the undersurface of the acromion and/or resecting a small section of the anterior acromion itself. A common technique involves a two-step procedure. First, an anterior acromionectomy is performed, being careful to maintain the critical deltoid origin, followed by an antero-inferior acromioplasty to meticulously smooth the undersurface of the acromion.
Reshaping the bone, essentially.
Exactly. It's also common practice for orthopedic surgeons to address other coexisting conditions during the same surgical session if found. These might include addressing acromioclavicular arthritis, arthritis between the clavicle and the acromion, or treating biceps tendinitis if the long head of biceps is also a source of pain. Crucially, any partial or full-thickness rotator cuff tears found during the diagnostic arthroscopy will also be repaired at this time.
Tackling everything at once.
That's often the goal. While arthroscopic techniques are the preferred standard, open surgery involving a larger incision may still be performed for more extensive repairs or in complex cases, as it allows for direct visualization. Now, here's where the conversation with our patients becomes particularly critical, and this is a key insight for our clinical audience. While surgical intervention is effective in many cases, especially when there's a clear mechanical impingement due to an osseous spur, the evidence base for its superiority over dedicated physical therapy is, well, nuanced.
Ah, okay. Tell us more.
A systematic review of randomized controlled trials, for instance, found moderate evidence suggesting that surgical intervention was not necessarily more effective for reducing pain than impingement-directed physical therapy.
Really? So physio can be just as good?
In many cases, potentially yes. Furthermore, a highly impactful 2018 systematic review, which included sham surgery trials, found no additional benefit in pain reduction when comparing arthroscopic subacromial decompression to placebo surgery at 12 months.
Placebo surgery? Wow, that's quite something.
It is. It raises important questions for us about patient selection and the power of the placebo effect, or perhaps just the natural history of the condition. Similarly, when comparing surgery combined with post-operative physiotherapy to surgery alone, no statistically or clinically significant difference was observed in terms of pain or function. We also observed poorer subjective outcomes in patients with workers' compensation claims or those with underlying anxiety or depression.
So psychological factors play a big role too.
A very significant role. These findings underscore the complex interplay of biological, psychological, and social factors that influence surgical outcomes, highlighting the critical need for careful patient selection and realistic expectation management.
That's incredibly powerful data. It really challenges perhaps some traditional assumptions we might hold about the necessity and efficacy of surgery. It reinforces the importance of meticulous patient selection and managing expectations. So, considering both conservative and surgical pathways, what can patients realistically expect in terms of recovery? What are the potential challenges and complications we need to foresee? And crucially, how can we as a cohesive healthcare team best support them through this entire journey?
Those are absolutely vital questions, bringing us to the holistic management of our patients. Post-surgery, rehabilitation is a structured and progressive process. Typically, the arm will be placed in a sling for a short period, perhaps a few days to a week, primarily for comfort and initial tissue protection. However, as soon as comfort allows, and under the guidance of a physical therapist, the sling is removed to facilitate early, gentle shoulder exercises and controlled arm use.
Early movement is key then.
Generally, yes. A comprehensive, structured rehabilitation program is then absolutely essential to regain full range of motion, restore strength, and ensure optimal functional recovery. While patients often begin to experience significant pain relief within 2 to 4 months post-procedure, it's crucial to manage their expectations. Full recovery, especially for those with chronic, long-standing issues or more extensive pathology, can realistically take up to a year. This requires patience and consistent effort from the patient.
A year is quite a long time.
It can be, yes. The prognosis for subacromial impingement syndrome is generally quite favorable, particularly with early diagnosis and appropriate tailored management. It's very encouraging for both us and our patients that conservative management encompassing physiotherapy, NSAIDs, and steroid injections yields satisfactory results in a significant proportion of cases, approximately 60% to 90% within 2 years.
That's a good success rate for non-surgical options.
A very robust success rate, which should always be our initial approach. However, as with any condition involving structural changes or altered biomechanics, there are potential complications we must be acutely aware of. These can include the progression to more severe rotator cuff tendinopathy or even full-blown tears, including issues with the long head of biceps tendon manifesting as bicipital tendinitis or tears. Adhesive capsulitis, commonly known as frozen shoulder, is another potential complication that can arise, particularly if the shoulder is immobilized for too long or rehabilitation is not initiated promptly.
Right, avoiding stiffness is important.
Critically important. Less commonly, we can unfortunately see deltoid dysfunction, which might result from a failed deltoid repair after open acromioplasty, or, more rarely, an excessive acromionectomy during an arthroscopic procedure. A critical surgical consideration, especially in cases of massive, irreparable rotator cuff tears, is to avoid extensive acromioplasty and coracoacromial ligament release, as this could paradoxically lead to anterosuperior escape of the humeral head, a very debilitating complication.
Something surgeons need to be very mindful of.
Absolutely. A point that cannot be overstated is the paramount importance of deterrence and patient education for long-term shoulder health and preventing recurrence. We must tirelessly emphasize the importance of unwavering adherence to both office-based physiotherapy sessions and, critically, the prescribed home exercise programs.
Getting the patient on board is key.
It's essential. Activity modifications are also key. Patients need to deeply understand the importance of temporarily discontinuing aggravating overhead activities until their pain significantly improves and their shoulder mechanics are optimized. Re-emphasizing the concept of living within the window, restricting movements to that comfortable 2 to 3 foot rectangle anterior to the body, is an invaluable piece of advice for long-term self-management and protection. It's about empowering patients to become active participants in their recovery.
Makes sense. Empowering the patient.
Exactly. Finally, enhancing outcomes relies heavily on robust, proactive, interprofessional collaboration within the healthcare team. This truly is a team sport, and effective communication is the linchpin. The primary clinician, often a GP or family doctor, plays a vital role in providing initial pain relief modalities, such as NSAIDs or corticosteroid injections, delivering initial education about the condition and making the crucial, timely referral for physiotherapy.
The GP as the starting point.
Often, yes. The physical therapist then takes the lead on office-based exercises and developing a tailored, progressive home exercise program. Routine, clear communication between the physical therapist and the primary clinician is absolutely essential to track progress, troubleshoot challenges, and guide any decisions regarding further imaging or potential surgical referral. When a patient becomes a candidate for surgical intervention, the orthopedic surgeon steps in, but their role is still integrated. Orthopedic nurses provide invaluable support throughout this process, assisting in assessment, delivering detailed pre- and post-operative patient education, and communicating any changes in the patient's status to the orthopedist.
So everyone needs to be talking to each other.
Constantly. A fascinating and increasingly recognized aspect we must consider as medical professionals is the profound influence of psychological factors on recovery outcomes. Aspects such as pain catastrophizing, where a patient has an exaggerated negative mental set during actual or anticipated pain, and their intrinsic patient expectations can significantly impact their recovery trajectory.
That idea of catastrophizing? Yes.
High levels of catastrophizing, for example, have been consistently shown to correlate with increased pain intensity, greater disability, and even impact employment status among patients with shoulder complaints. This powerfully highlights the need for a truly holistic approach to management, addressing not just the physical pathology, but also the crucial mental and emotional aspects of the patient's experience to achieve optimal outcomes. We need to be screening for these factors and incorporating them into our management plans.
A truly biopsychosocial approach, then.
Precisely. That's the idea.
Professor, what an incredibly thorough and insightful deep dive into subacromial shoulder impingement syndrome. Really fantastic. From its intricate anatomical underpinnings and that dynamic continuum of disease, through to the nuanced diagnostic pathways and the latest evidence guiding our management strategies, you've truly illuminated the complexities and provided invaluable, actionable insights for us as clinicians. It's abundantly clear that while this condition is common, it demands a nuanced, integrated, and patient-centered approach for optimal outcomes. Considering the sheer prevalence of shoulder impingement and its often chronic nature, perhaps a final thought. How might we, as a medical community, better integrate preventative strategies into routine care, especially for high-risk populations, to truly shift the paradigm from reactive treatment to proactive well-being? Something for us all to think about. If you found this deep dive valuable for your practice, please do take a moment to rate and share Deep Dive Ortho with your colleagues. Thank you for joining us on this deep dive. Until next time, keep exploring, keep learning.